And now we are here to talk about COVID-19 vaccines and the RASopathies. But I'm going to go over a few things about RASopathies Network first. So the RASopathies Network, our mission is to advance research to improve the quality of life for RASopathies families by bringing together families, clinicians, and scientists. We believe that by bringing all the syndromes together, we can learn more and advance research more quickly. And I wanted to say thank you to Elizabeth Parker. Today is Elizabeth Parker's last day on our board. Elizabeth has given 4.5 years to the board to help improve outreach to families on social media, has updated our logos and branding, has fundraised to help advance RASopathies research. She's made a lasting impression on RASNet, and we can't thank her enough. I'm going to go back one slide to say here's our board of directors. Lisa Scheuer's traveling today, so I'm not sure if she's gonna make it. She's on a flight today, but she might just call in a little bit later if she can. So I will also be rotating off the board. I'm Lisa Schill, the Vice President of RASopathies Network, and I will also be rotating off the board after 8 years of service. At the end of the month, I will still be around to help out. So will Elizabeth, but just in different ways. We love the RASopathies Network, and we will continue to help make it grow. So I would also like to talk about the $1 Million Bike Ride. This is one of our programs we do in partnership with the University of Pennsylvania for raising international RASopathies research funds. I know Dr. Gelb has ridden with us 1 year, which was really nice, and he's also received funding from the grant. And so far to date, we've actually raised $500,000 in this program and towards RASopathies research. And these grant award recipients also present their research at our scientific symposiums. And this year, thanks to you and to the University of Pennsylvania, we have a grant for $75,431 to be given to advance research specifically for CFC, Costello, and Noonan syndrome. We're about to collect applications for the grant, and we'll announce the award recipient in January of 2022. So thanks again for all your help with that. We also just had our 7th International RASopathies Symposium. Dr. Amy Roberts was a chair of the meeting with us. And if you weren't able to attend, you can review the abstracts of the presentations and view the posters that were submitted on our website. And we're also working on a publication about the symposium. And please visit rasopathiesnet.org for research opportunities. Once you get to our main page, just click the research tab at the top and then click on research studies and clinical trials. These are for families. We could not advance research without your help. And the National Cancer Institute is conducting a longitudinal natural history study of the RASopathies. We're really excited about this. The RASopathies Network has been a part of this since the beginning. The NCI would like to learn the history of about 1,000 families to see what our commonalities are, how many families have heart conditions, lymphedema, seizures. So to learn more about this study, please visit rasopathies.cancer.gov. And you can also find this information on our website. And Dr. Green is continuing her study of Noonan and neurodevelopmental issues. She has also added NF1 to the study. Please reach out to her if you'd like to learn more about this study. It's also on our website. You would need to travel to California, but travel costs would be covered. I know that my son participated in this research study, and it was great to get the comprehensive neurodevelopmental evaluation. Then we also have a parent, Tina Wang, who has a 10-minute survey to learn about healthcare information, what healthcare information families would like and need. This survey is only open until August 27th. But again, this SurveyMonkey is listed on our website in the research studies section if you'd like to learn more or participate. And we also have a contact registry. This registry is used to inform you of research study you might want to participate in. An email will be going out to all those in our registry this week about these 3 studies that I've mentioned today. And to join the registry, please just contact info@rasopathiesnet.org if you're interested in joining. We never share your information. It's just to inform you about studies. And with that, I'd like to introduce Dr. Gelb, Dr. Stevenson, and Dr. Roberts, who will be talking today about COVID-19 vaccines and children with RASopathies. So I'm going to hand it over to Dr. Gelb.
Okay, thank you, everyone, and welcome. Glad you were able to join us today. For those that were on last time, the first few slides I'm about to show are going to be pretty similar. After I speak, we're going to go on, I'm not sure which order we're going, but to Dr. Stevenson and Dr. Roberts, and then we'll do a Q&A after. And for that, primarily, I think we'll ask people to put their questions into the chat. But as you think of questions as we're going along, that'll be fine. Okay, so I'm just doing a bit of an intro about COVID, both the virus and the disease. So off we go. And hopefully I won't hit, I'm not advancing either. Okay, so just so people know, coronavirus, which is obviously the cause of COVID, is not something new. In fact, the human coronavirus was discovered 80 years ago. It's named for the fact, corona means crown, of course. It's named for the fact that if you look at the virus, as shown here under an electron microscope, it appears to have a crown around it. There are many coronaviruses that affect humans. There are 7 that we know of so far. 4 of them cause the common cold and are quite mild. And then there are 3 that we know of that cause relatively severe disease. So the first was SARS-CoV at the time, because it was the first. That was a severe respiratory syndrome. The second was MERS, which was arose in the Middle East. And then, of course, now we're dealing with COVID-19, which is caused by SARS-CoV-2. Oh, this is fun. Okay, so how are these viruses transmitted? And the basic answer is it is primarily a respiratory virus, and it has 3 ways that it can be transmitted. 1, through droplets, or which are relatively larger particles, which you can see in the somewhat disgusting picture of somebody sneezing shown on the right there. Airborne are more difficult because those are the very fine particles that can float in the air for quite some period of time. And then, especially earlier on, there's been concerns about contact, and there probably is some transmission by contact, but that's much less important. So overall, we believe that the transmission, the most important are droplets, the second most important is airborne, and the final is contact. And that's of some importance in terms of strategy for reducing transmission, because masks are known to be quite effective for blocking droplets and causing them not to go out directly in front of people. Social distancing, you know, the 6 feet rule that we all are aware of is based on the droplet, and hand washing obviously is more important for contact. The symptoms of COVID by now are pretty well worked out, and they include everything listed here. Most of these things are really just flu-like illness. I would say the top 6 on this list, that would be the case. I think what has set COVID apart is the loss of taste and or smell. I should note, Dr. Roberts will talk about Delta. There's a little less of that as far as we understand it with that. Sore throat continues to be a problem. And then the thing that has really been challenging, I think, is the fact that there's asymptomatic disease. People up to 15–20% of cases will have no symptoms and yet be infected and therefore able to transmit. That's one of the problems. COVID has been very much a disorder of the elderly, and that's not a given. We're used to that from our annual flu, but I'll just remind people, if you don't know it, if you go back to the history of the 1918 influenza pandemic, that was not as brutal on elderly people. It was really a middle-aged person, young person's disease. So it's not always the case, but it is the case here, and that's certainly been great for our children. And the numbers that I'm posting here are what we've come to understand from what we shall call COVID classic. So you can see that in elderly people, by the time you get to age 85, the case fatality rate, meaning of people we know infected, how many will die, is quite high at 1 in 7. But by the time you get down to 10-year-olds, it's 1 in 50,000. It's quite low. And as far as I know, and Dr. Roberts maybe can speak to this, I don't think we yet have comparable numbers for Delta. So we just don't know whether that's true or not, whether the numbers might be higher, for instance. Okay. We've also learned that the risk of COVID is not equally distributed amongst people, that people with certain underlying medical problems are certainly at higher risk. And I've listed them here. And certainly, as we think about RASopathies, things like heart conditions certainly become important. But we're talking about people who are typically sick with their heart conditions, namely in heart failure, not just getting along fine with a little bit of disorder. Unfortunately, there's also social inequities that play into the lethal rate of COVID-19. And we've seen that in persons of color. This has been higher, same with the poor. And all of those are probably tied up with things like living conditions and occupation, who's on the front line and being exposed versus who has the ability to work from home and therefore limit their exposure. So recently, this is the most recent data in terms of the daily case rate. You know, it's hard to imagine, but I mean, I live in New York and I remember vividly when we felt we were being rolled over by this wave, which in hindsight turned out to be pretty small. And then later that year, over the summer, it really, it sort of spread across the country. I think everybody's aware that last fall and into the winter, we really got, it was crunch time, a little bit more of a wave in the spring. And then once again, we're seeing a wave due primarily to Delta. And again, Dr. Roberts will speak to that. It's a little early to say whether that wave is peaking. You could sort of squint your eyes and hope that maybe we're near the peak of that. But I don't think we can really say that yet. As you can see, the data are very noisy because some days, some states report, others don't, more testing during the week than on weekends, and so on. So there's a lot of noisiness in the data. So it's too soon to say where we'll peak and how soon. This is the daily death rate due to COVID. And you can note that even though the wave at the very beginning was not nearly so big, we lost a lot of people. And that's because at that time, we really hadn't figured out how to treat the disease. We've learned a lot, particularly the use of steroids have emerged as something very helpful. And as a result, the subsequent wave, which I showed you was bigger in terms of cases, had a lot less fatality. And relatively speaking, even though we lost, you know, horrific numbers of people per day, we did better last winter relative to the rates we saw here. And it appears that that's holding up here with the current wave. I think it's a little too early to be certain because usually there's about a 3-week lag between when people get sick and when people pass away from COVID. So I don't know how high this peak's going to get, but we should know that within the next couple of weeks. But at least looking at other countries, it appears that the increased abilities of or improved treatment is helping. And the other thing that's helping us is, as I'm going to show you with vaccines, the people being infected now are a younger group than before. So the fatality rate, the case fatality rate is lower. How are we doing with vaccinating people? So this is the most recent data from the CDC. And of course, if you look at all ages, we have only 50% of the population, but you have to remember that anybody under the age of 12 is not eligible currently for a vaccine. So if you focus just on those that are 12 and up, so people who could get the vaccine, we have about 70% who've had one and 60% are fully vaccinated. And then the interesting thing, I think, is when you get to the elderly, the people 65 and up, and I use the word elderly with a gulp since I'm very close to this age, actually, we've done pretty well, even though there are big differences across the country. There are states like Vermont where they've done incredibly well, and there are other states such as Florida and Texas where the rates are much lower. Actually, if you look at the rates of vaccination in the elderly across the country, they're actually quite high. Still a bit higher in a place like Vermont compared to, I don't know, Louisiana, but nonetheless, it's much more even. So the struggle really has been the people between 12 to 65, where in some parts of the country, the rates are pretty low. There has appeared to be a bit of an uptick in people getting vaccinated as the word has gotten out that Delta is really causing problems, and we're seeing the numbers spike in some of the states where there is not very high rates of vaccination. So people, of course, worry about side effects from vaccination. So I just want to quickly throw up the numbers that we have about that. In terms of not serious side effects, things like local pain, a little fever, a little tiredness, those rates are pretty high. But I think people find that normal. You know, if you get your annual flu vaccine, you can have a little bit of flu symptoms, and that's been the case here too. But in terms of the serious stuff, the first thing that we talked about was having an overwhelming allergic reaction, sometimes called anaphylaxis. That turns out to be quite rare at somewhere between 2 to 5 per million persons who get the vaccine. And those are persons who have an allergy, a very unusual allergy to one of the parts of the vaccine, which is called polyethylene glycol. It's a pretty unusual allergy, and we really haven't seen very much. The second thing that emerged was the problem with blood clots, particularly in young women. That was fairly scary. The numbers turn out to be, again, very, very low. For the J&J vaccine, it's about 3 in a million. And to the best that anyone knows, this is not a problem with the RNA virus, the modified RNA viruses, Mrna and Pfizer. The most recent thing, which I think has also been scary to hear about, at least initially, has been the possibility that after vaccine, there would be inflammation of the heart, so-called myocarditis. So here it's flipped. So the J&J vaccine, there's been none of that so far. For the Mrna and Pfizer vaccine, the current estimate of rate is overall is 5 in a million, but it should be said that that's not evenly distributed. So it's higher in people, teenagers and young adults, particularly if they're male. So the rates in that group of young adolescents who are male or young adults who are male is about 30 per million. This occurs about 2 to 3 days, most typically after they get their second shot, not the first shot. But the good news is, even though it sounds scary, so far, it really hasn't been a huge problem. The course is limited, self-limited, without treatment, it goes away. And knock wood, to date, there's been no deaths. I'm not going to say, of course, that there couldn't be someday, but so far, it's been pretty mild. The boards that monitor side effects from vaccines or other drugs are keeping a close eye on that. But for now, this has not been something to think about stopping. So we're still full speed ahead. And I think the bottom line on all of these side effects is that so far, if you do the math, even for young people, the protective effects pretty strongly outweigh the bad side effects. So for instance, if you look at young people in big numbers, you would expect the number of people who would die if they weren't vaccinated to be 6, and the number from bad effects from the vaccine to be 0. So it's really not close. And then, of course, if you look at serious illness, needing ICU, problems like long haul and so on, it's really not the same at all. So that's why it's still full speed ahead. And then the last slide here, I'll just mention the other problem which arose a little more than a year ago was this thing that we're calling MIS-C, which is an abbreviation for what I've written here, multi-system inflammatory syndrome in children. And so this is something seen in children. It's also seen a little bit in young adults. It occurs about a month and a half after infection. It's not related to vaccine, only infection. And the patients show up with just inflammation affecting many organs. It's very diffuse. It can affect the kidneys, the heart, the lungs. They're really quite ill on presentation. I don't know, I probably don't know the current numbers, but there have been over 1,000 cases, and the number of deaths has not been that high from it, thank goodness. I think that as we've learned about that, it's still under study. We've gotten much better at treating it, and so patients are even doing better now than a year ago. There's no predisposing factors. In fact, it's been primarily in youngsters who were completely healthy with nothing that would make you think that they would get sick. So I would not think, I'm not aware yet of I'm sure at some point it'll happen, but I'm not aware of a person with RASopathy who's had MIS-C, but there's no reason to think that such individuals are particularly at risk. So that's the end of my slide. So I'll stop there. And I'm not sure, David, were you going to go next?
So yeah, I'm going to talk a little bit, and then Amy, Dr. Roberts is going to close. So I've been asked to talk a little bit about pediatric vaccine availability and also about dosing. The reality, talking about the pediatric vaccine availability, there's not a lot out there because it's only available with the Pfizer BioNTech vaccine for those 12 years and up. Currently, both Moderna and Johnson & Johnson are not approved for pediatric use. But we do know for those individuals that are 12 years and up, between 12 and 18 in the pediatric range, that there is the availability for vaccination with Pfizer. That being said, I thought I'd talk a little bit about the pediatric trials. Now, these are clinical trials, and so we don't have data. We don't know the efficacy, so we're still trying to figure that out. And we should hopefully know in the future, near future, I hope, but there's a little bit of question mark about when these trials will be done. When we look at clinicaltrials.gov and what's been reported, Pfizer is currently being performed in 3 groups. They're doing the 5 to 11-year-olds, 2 to 5-year-olds, and then 6 months to 2-year-old. Moderna trials, their 12 to 17-year-old trial was completed, so it's currently being reviewed, and they're looking at that data. And they're also performing a trial on individuals from 6 months to 12 years of age. There is a question about how long to follow these kids and whether or not to increase the participant numbers. There's been a request by the FDA about increasing the numbers in those trials. In terms of dosing, because that's been a question about what's the dose. Currently for Pfizer for pediatrics, it's the same dose as those that are adults. So it's not based on weight, but really it's kind of, even when we're doing clinical trials, probably based more on age and the immune response. When we think about vaccinations and other medications, it's different. For other medications, you're really aiming for a kind of concentration in the blood. But for vaccines, you're delivering it to the muscle, and your cells are then having an immune response that then will generate those antibodies. And you really don't need a lot for your body to make that, have that immune response. So in clinical trials, the doses usually begin at the lowest, safest level, and then increase to determine if a larger dose is more effective, but they want to have the lower dose to provide an adequate response. So those are the different phases of clinical trials. Usually a phase 1 is to identify the preferred dose level, and then phase 2 and phase 3 trials really evaluate the safety and tolerability and the immunogenicity of each age group. And when we just think about what is being given, for Pfizer, it's 30 micrograms per injection for everyone 12 years of age and older. So there's one dose. For Mrna, it's 100 micrograms per injection for adults, but it's not being administered right now in pediatrics. But in the clinical trials, they are dosing in younger ages. And for Pfizer, they've selected 10 micrograms for the 5 to 11-year-olds, and for the 2 to 5-year-olds, it's 3 micrograms, and the 6 month to 2-year-olds are also using 3 micrograms. For Mrna, their clinical trials are in the earlier phases where they're trialing different doses, 50 micrograms and 100 micrograms in 2 years in age and up. And for the 6 month to 2 years, they're doing 3 different doses, 25, 50, and 100 micrograms. But really the bottom line is, it's probably not based on weight. And I think that's been some of the questions that have come about from the RASopathies is, if our children or individuals with a RASopathy are smaller, should they be getting a different dose? And the real answer is no. At the moment, we don't have any evidence that we would think that you would need to have a dose based on your actual weight, but it's probably on your ability of your immune system to generate a response. And we do know that adults, your kind of ability to generate an immune response does decrease as you get older. So you might need larger doses based on your age. But currently, that's what we know in terms of dosing, and the clinical trials hopefully will be out soon, but we just don't know how long it will be until we will have, or if we'll have a vaccine for individuals that are less than 12, and those clinical trials are ongoing. So that's all I had, Amy. So I thought I'd turn it over to you.
Great. Excuse me. Thank you. So I was asked to answer some of the questions that were submitted ahead of time. So I have a number of different topics, but I'm going to keep my comments brief so that people can ask follow-up questions, and we'll have plenty of time for that after I cover a little bit of ground. So first, I'm just going to talk about the Delta variant in general, what we know about it, and probably as importantly, what we don't yet know about it. It looks like about 80% of the current infections in the US are Delta. Symptoms are largely the same. There's a suggestion that maybe it's less prevalent to lose your sense of smell, but otherwise not necessarily different than the original form of COVID. It does, though, appear to spread more quickly and more efficiently. There's a concept called RASNet, which you've probably read about if you've read about COVID-19, which really is a way of describing just how contagious a disease is. Original COVID-19 had an RASNet of 2 to 3, which means that on average, each infected person spreads it to 2 or 3 other people. And in contrast, it's thought that the Delta variant's RASNet is probably about double that, so much more contagious. It also is thought to reproduce more efficiently. And so when someone has it, they have just much more virus in their nose. And that's likely contributing to how much it's being spread. Original COVID was thought to really not be spread by people who were fully vaccinated, but we have seen that the Delta variant can be spread by fully vaccinated people. Fully vaccinated people, though, are very well protected from the Delta variant, about 88% effective in preventing any kind of symptoms and 96% effective in preventing hospitalization. But breakthrough cases do occur, and we hear a lot about them, but they are quite rare. It's thought that the breakthrough cases of people who are vaccinated getting COVID is about 0.01 to 0.29%. But it feels like more of that just because 0.29% of 166 million people is 500,000 people. So it's still a small percentage of the total, but you know, as an individual, your risk is low. Because fully vaccinated people can spread Delta, we do think about it a little differently in terms of what precautions to take. It is thought, though, that people who have the Delta variant who are vaccinated are infectious for a much shorter period of time and much less likely to acquire it in the first place than people who are not vaccinated. That's because their immune system kicks in that was triggered by having had the vaccine and eliminates the virus, and then they're no longer infectious. It has not been shown that severe COVID is more common in children with the Delta variant than the original COVID, or that medically complex children are more vulnerable to the Delta variant. It's still true that fewer than 2% of kids with COVID will require hospitalization. We can look to the UK, which had its Delta surge earlier than ours, and they reported that the Delta variant did not make up an unexpected proportion. Kids did not make up an unexpected proportion of the surge in the UK because of the Delta variant. There are about 50 million children that are younger than 12 in the US, and recent numbers are showing that a lot of kids are getting the Delta variant of COVID. For the last week of July alone, just that week, last week in July, there were 72,000 children who were reported to have COVID. And that's more than a fifth of the total number of infections in children for the entire duration of the pandemic. A week after that, it went from 72,000 cases in 1 week to 94,000, about 94,000 cases in 1 week. So there are a lot of kids that are getting it. And while severe cases requiring hospitalization are rare, when thousands of kids get the virus, then there are more cases that we hear about, more cases in the hospital. There was a question about vaccine mandates. It's been suggested that strong mandates are appropriate in high-risk settings where vulnerable people really don't have a choice about being exposed. For example, hospitals, long-term care facilities, and prisons. And also that it maybe would make sense to have vaccine mandates in other places where individuals are already asked to have medical conditions to meet particular medical condition requirements like universities, government employees, and the military, where you have to have other vaccinations to be a part of those groups. There was a question about herd immunity, and that's when most of the population is immune to a disease, and this provides protection to those who are not immune. The percentage of people that need to be immune depends on how infectious a disease is, and it's estimated for COVID that we would need 70 to 90% of the population to be immune. And then Dr. Gelb pointed out that as of August 13th, 59% of the country of those who are 12 and older are fully vaccinated. So we'd have to really up our numbers to get between 70 and 90% to be depending on huge herd immunity. There was a question about booster vaccines. I think it was just this week that the CDC came out and recommended a booster for those who are moderately or severely immunocompromised, though did not go on to define what that meant. They did give some examples like cancer patients, those who've had organ or bone marrow transplant, or those with significant immune deficiency, and recommended getting that third dose at least 28 days after the second dose. For those older than 12, that would be Pfizer, and those older than 18, it could be Pfizer or Mrna. There are a couple of countries that are giving booster doses to the general population, but the World Health Organization has asked countries to really be very thoughtful and not do that in an effort to get first and second doses to countries that don't have vaccine at all. And then, of course, there's a question about masking and the appropriateness of masking and the need for masking. There's a recent study out of Duke of infections in North Carolina schools. It included 100 school districts and 14 charter schools, and it found a strong efficacy of masking in decreasing COVID-19 transmission in schools. And the CDC recommended universal masking in schools for everyone over age 2, for kids and teachers, regardless of your vaccination status. Other areas where rates of transmission are very high are also reinstituting, in some instances, mandatory masking for indoor settings. So those were my comments. And because I was talking, I wasn't looking at the chat, but maybe we can look at the chat.
Yeah, there are a couple questions there, Amy.
Okay.
Now 3, I think.
So Bruce, do you want to take the question about myocarditis?
Sure. So somebody's, and by the way, we will try to answer questions in a generic way. We're not here to be your doctor. If you have real questions about your particular child, please consult your own physicians. But so the question is, how about a younger kid and the risk of myocarditis if the child has RASopathy and heart involvement? So the myocarditis so far is an effect of the vaccine. We don't have the data yet on the trials. Dr. Stevenson described that. We don't know yet the results of the trials for kids in the 5 to 11 year age range. And so I have no idea. As I mentioned, the myocarditis problem is very age specific so far. It's in teenagers and young adults, and it's particularly in males. So, I mean, one can make a guess, but it may be not at all in younger kids. It could be worse. I mean, I have no way to know, before we see the results of the trial. I would say that if a child has significant heart problems, is really sick, I would still say that it's highly likely that the risk of COVID as an infection is much more risky to that individual than the chance of getting a side effect of the vaccine. So I would argue that if the vaccine gets approved this fall or maybe January, the Pfizer vaccine for kids, and your child is eligible, your best strategy is to get your child vaccinated and not to worry about the rare side effect. I think the risk of the virus and the infection is a lot higher.
And then there's a question about, and we've kind of talked about this, but are there any data about the risks of severe illness from COVID, specifically for people that have RASopathies? And I don't think that we have any real data to say that somebody that has a RASopathy would be much more severely affected. I don't think we've heard that. Obviously, if somebody had a significant major problem like severe heart disease, then they potentially be at risk. But I don't think we have any data. Amy and Bruce, do you have any other thoughts on that?
I think you've hit it exactly right. I think that the one piece I'll put in there that's probably worth mentioning is where we do have risks for some individuals with RASopathy is around their developmental disabilities. So that is not specific to RASopathies. That's a problem in general. I think as we potentially look at back to school in the fall, I think it's clear that getting individuals who have let's say moderate level or worse developmental issues, more difficult to get full compliance with mask wearing and distancing. And so there's a little more transmission risks, I would say, for that group. Schools are very much aware of this problem. And I think most schools are trying their best to use all the strategies that are available to them. A lot of those strategies are not so obvious to us, the rest of us. You know, there are all these things about air handling, for instance, which schools are putting a lot of effort into thinking about, and presumptively they would be doing that, you know, for your kids in your classrooms too. But that's the only thing I know about in terms of risk for children with RASopathies. That's different than other children or typical children.
And then another question was, are there any reasons to believe that the risks of the vaccine are different for people with Noonan syndrome or the RASopathies? And I do not think we have any evidence to suggest that that's the case.
Correct. I think that's right. Amy, are you frozen? Yeah, I think she is. Yep. David, should we go on to the next?
Those are all the questions right now.
No, there are more. So Lisa Schill
I'm not seeing
reminded us about the question about MEK inhibitor. So thank you, whoever mailed that in. That sent us scurrying to the literature to figure that one out, because stump the chump, I didn't know about that. So what the parent is asking is whether, if your child has a RASopathy and happens to be on, let's say, trametinib, could that be protective for your child? Because there's a little bit of literature that the SARS-CoV-2, the virus, needs, when it's in the cell, it actually needs the RAS pathway in order to make itself happy and you know, take over the room and start replicating itself and so on. And there is a company that possesses rights to a MEK inhibitor that announced about a year ago that they were hopeful that they were going to develop a MEK inhibitor specifically as a treatment for COVID-19. So I would say, while that's all very nice and intriguing, a few points to make. Number one, that would be a treatment strategy, not a preventive strategy. So the idea here is to prevent people from getting very sick. And then the fallback position is to get them better if they're getting very sick. So MEK inhibitor might fall into the second category, but we have no reason to think it prevents infection or initial illness. So I would say vaccines are our best strategy. That's the first point. And perhaps as important or more important, at this time, we have no data in patients to show that use of a MEK inhibitor actually works to prevent, you know, to get people better. So right now, you know, there's no hospital I'm aware of that's giving a MEK inhibitor when an adult or a teenager shows up with terrible lung disease from COVID-19. We just don't have data. Could that change in a month or whatever? Of course, and we'll all keep our eye open for that. It would be great, but for now, that's not reality for now. Yeah, there was also a parent whose child has NSML who asked about vaccine, and the child has severe HCM. So the answer to that is the same. If there's severe heart disease, the risk really is getting the disease. Obviously, right now in a 6-year-old, you can't vaccinate. So what do you do? The best you can do is use the strategies. You want other people in the home who are eligible to all be vaccinated, and you want to use the precautions with masks and so on as best you can. David, there's a new question.
So relatedly, any thoughts about the use of ACE inhibitors and how those might impact risks of infection or severe disease from COVID?
So I think what the person is thinking about is, so viruses have to, they're on the outside of the cell and they have to get in. And so this particular virus uses a receptor that's related to ACE. It's the same thing that the drug sort of goes at to some extent. And so there was a thought that ACE inhibitors might be protective. To my knowledge, there have been no trials of ACE inhibitors. I think what has happened is that after people had that somewhat clever idea, they went and looked at large data sets from hospitals to try and see whether their patients who were on ACE inhibitors did better in terms of when they got COVID, and there was no evidence of that. So that was sort of an early idea. To my knowledge, that's fallen to the wayside with some of the other ideas, hydroxychloroquine went bye-bye, and so on. And so really, right now, steroids have been, what's made the difference in terms of how patients do in the hospital.
So I don't see any additional well, here's one just came in. Yeah, Amy, I think this is probably for you about masks, and this is a controversial topic, but asking, school not mandate masking, and most parents in our area are not planning to have their kids wear a mask. How protected will our child be if she is one of the only people wearing a mask?
Yeah, that's a great question. And as you could imagine, it's a hard thing to study. But there have been some studies looking at school districts like that, where there was a voluntary masking, and then other places where masking was mandatory. No comparison to no masking at all, just those two groups. And it will come as no surprise to you that there's more school spread when you have voluntary masking. I think it is known, though, that the mask is helpful both for preventing spread, but also preventing infection. So it is helpful to your child as long as your child can keep their mask on. And you mentioned that your 7-year-old is quite healthy. So I don't know, I think there's not a solid answer to this. It also has to do with sort of how you feel, where you live. If you lived in a place where the transmission is extremely high, I would be thinking about that pretty differently than a place where the vaccination rate is very high. But it does afford some protection. It's just not, as you could imagine, not as good as having everybody masked.
Can I just throw in a little to add? I alluded to this earlier. Masks are important, but they are not the only strategy available. And obviously, we're starting to see, particularly in the states where governors have and legislatures have decreed that schools aren't allowed to do mandated mask wearing. The schools are pushing back a little bit, but schools will use other strategies as well that are also known to be helpful. So you may not be able to, have forced masking, but you can still do social distancing. And they will do things with the way they handle the air, to the extent, and depending on what part of the country you're in, they may be able to have the windows open. Obviously, that's not going to work in Massachusetts in January, but there are parts of the country where it's still warm enough, and air circulation turns out to matter a whole lot. And schools are doing the best they can. They're actually measuring stuff like that. So hopefully your school district is taking that seriously and doing as much as they can, given the specifics of the physical plant, to up the circulation so that that will help as well. So the combination of having your child wear the mask plus the other things the school is doing should make a substantial difference. It would be better if the other kids were masked. I don't think we can get around that fact.
So there was a question about the use of ivermectin, and as far as I know, it's not a proven treatment. I don't know a lot about it. I don't know about you, Bruce, or Amy.
I don't know either.
No, I don't know. I'm sorry.
Bruce or Amy, do you have anything else that you'd like to bring up?
Yeah, I want to say something optimistic, and that is, I want to say two optimistic things, actually. One is that I do think a fair amount of data has emerged about the ability to open schools safely. That overall, in communities where schools were open, and a lot of this is not in the United States necessarily, a lot of the experience has been in Europe. They've shown that is not the driver of transmission of this virus in communities, frankly. And so I do think, and we're better off this fall than we were a year ago. I mean, the teachers are going to be largely vaccinated for sure. And hopefully in many communities, at least at the high school level, and maybe some of the middle schoolers, depending, where the cutoffs are, I guess, there will be individuals who are vaccinated. So I think those things are going to be helpful. So I do think, and I do think how much we're losing for children by not having them be together from a social perspective and a learning perspective is very much on everyone's minds, and I think rightfully so. And I think for those of you that have children with at least some developmental issues, I think we know that being in the presence of other children for learning is a driver. And so I do think there are compelling reasons to try and get the kids back together. The second optimistic, so personally, I'm quite supportive of if schools take the right precautions based on what we know now, that trying to open schools is a good move. Will it work out? I think we'll find out. If you look at the curves from places like the UK, their Delta, surge went away rather abruptly. It looks like the same happened in India. So if that's true, we may see ours go away fairly abruptly within another month or so. So that would be optimistic as well. The other thing is, I think a lot of us have started to say, well, like, when does this ever end? I mean, like, we keep hearing about new variants, and is it just going to be like for the rest of our lives that we're going to be wearing masks and distancing and new vaccines and boosters? And like, when does this ever end? And I don't have a crystal ball, so I'm not going to sit here and tell you I know the answer to that. But there are a few things to say that are helpful. We don't need the virus to go away. So here's a fun fact. If you look back 100 years ago plus to the 1918 epidemic that was caused by influenza, it turns out that flu is still with us today. That mutated versions of that flu still circulate and occasionally make up part of our annual flu. And our systems handle it. We know how to deal with it, and we'll get there with this coronavirus. I think it's unlikely the coronavirus goes away. It's expected it will be around, what we call endemic. But it will come to be that we'll have enough immunity that it'll be okay. It may be that we need vaccines for this every year, but we will be able to live a normal life with it. That's one thing. The second point was something I've been thinking about, and then I read a really cool piece in New Yorker this week, and that is, obviously, the reason Delta is so much worse than Classic is that it's mutated. Well, it turns out that when you have bugs, be they bacteria and viruses, this is what they do. They evolve and they get worse, but they do that early in their evolution. There are not infinite possibilities for the way that the genome of SARS-CoV-2 can change and still be a virus that infects people and be worse and worse and worse. This is not going to be the case. Almost certainly, the experience with other pathogens is that they plateau. They get worse for a while to an extent, and then we've already selected out the worst ones because there are many different mutants. Most of them die on the vine. We're only seeing the ones that are a bit more effective than the original. And that means I can't say when, but this will not go on forever, getting worse and worse in jumps, the way we see that Delta is worse than Classic. So, and maybe Delta will be just about the worst we see. I don't know, but it will not. I can tell you with high likelihood, not certainty, but high likelihood that it will not continue to get worse indefinitely. And we may be at just about as bad as it gets with Delta, as far as I'm concerned.
There were some questions about emergency use and the FDA and requirements of vaccines in younger groups. And a question about would a diagnosis of Noonan syndrome be a medical exemption for vaccine?
No, there are currently no recommendations for people who should not get, within an approved age group, that is, should not get the vaccine unless you've had an anaphylactic reaction to the first dose. That's the only group that the vaccine is not recommended for. So a diagnosis would certainly not, of Noonan syndrome, would not be a medical qualifier to not get the vaccine.
Do you want to talk about the EUA, Amy? The difference between that and approval? Do you have thoughts?
Yeah, so yeah, I mean, I think that the mechanism under which everybody who's been vaccinated so far is through emergency approval, which is not the full FDA approval, but it's when the FDA says that it's okay because the illness itself is so significant. I think maybe there are some people who are waiting for FDA approval, but that's just a sort of a longer term analysis of the data. I think no one can, I don't know that children could be, I think there was a question about children being forced to have the vaccine under the, if it was approved for emergency use and under 12, I don't think that could possibly happen. Before there's full FDA approval. There was also a question I wanted to address about the mRNA vaccine and just differentiating it and having some concerns about what the long-term, we don't know the long-term effects. I just want to point out that in the end, your body is doing the same thing as it does to all of the other non-live vaccines that you've ever received. The mRNA part of the vaccine is in your system for a very brief period of time. And then what results, and the reason that you're immune is because your immune system has made antibodies. And that's exactly what it does when it encounters a non-live vaccine, other vaccines that you've gotten. So there's no reason to think that that there would be some unusual or unexpected long-term effects just because the way that your immune system got primed with the COVID vaccine is because of it's an mRNA vaccine versus a non-live virus vaccine that most of us have gotten our whole lives.
One thing maybe to add, Amy, is people raise, and I see the questioner did, like, well, we don't know the full health effects yet of this vaccine. A few points to make. One, it's unusual in medicine to come up with a new treatment or vaccine or whatever and have this many people get it. So, I mean, at this point, including the experience around the world, the numbers are staggering of people who have gotten it. So in terms of the short-term effects, I think we have a pretty good handle on what can go wrong. I think we're keeping a good eye, and I think, what I presented is what we know. The second point is, then people say, well, how do you know that 10 years from now, noses won't start falling off or something? I don't know what. And the answer is, of course, you can never answer that about any new therapy. That's fair to say. On the other hand, I do think overall we have a lot of experience with vaccines in medicine over more than 100 years. And when there are problems from vaccines, they occur shortly after vaccination. It has not been the case so far with vaccinations that we suddenly see problems years and years down the track. Because if there's going to be a problem, it's due to that acute reaction that Dr. Roberts was just talking about. So I mean, again, nobody could say 100% because until we're 10 years out, we're not 10 years out. But I think the likelihood of that is so remote. And again, recall, we are balancing it. I mean, the estimates are that if we just left all the kids unvaccinated, we'll lose 1,000 kids in the US. That's what we're talking about. And we have no reason to think that anything close would happen from the vaccine. There's just not side effects. Amy, do you want to address the new question? Somebody's asking if it's true that this is the first mRNA vaccine approved for use.
I believe it is. Is that the wrong answer? I don't know.
No, that's the right answer. However, the other piece of the answer, though, is to say, while this is the first approved use, the reason it went so quickly is that the platform of making mRNA vaccines was very well developed. It had been supported by the government for quite some time, and they were using it for a number of other things in the past and had already been giving it to individuals. So I think they were working on one for Ebola, for instance, and so on. So there were a number of people who had gotten vaccines, mRNA vaccines already. So it was not novel to use mRNA vaccines at that time. And part of the reason it moved quickly is we already had a lot of safety data to know that as a general concept, mRNA vaccines were safe. The only question really was whether making these proteins, the spike proteins, which is the protein they're making, is whether that was safe in the way in our immune system would respond. That's what had to be studied, because it is true that sometimes with vaccines you get the immune response in a way that is not helpful, that can be damaging, and that's what they had to test for, aside from making sure it worked against preventing the virus, which was also important. And so far, as we've talked about, that the signals are fine. It's really remarkable, actually.
I agree that they've been tested for a long time, and there have been a lot of different mRNA vaccines that were in different phases of trials. So I think we had a lot of safety data, even though this is the first, I think, mRNA vaccine that's been approved.
Yep.
There are other mRNA medications that have full FDA approval.
True, also.
For amyloidosis is one. I don't know if there's others, but I know that for a fact.
Yep. Thank you, Lisa. Good point. Okay, Lisa, do you want to take us to the end here?
Oh, I just wanted to say can I say one thing, Lisa? I just wanted to say thanks for all the questions, and thanks for being so thoughtful about this. I know it's different to make a choice for yourself than for your children. And I understand it's overwhelming and it's a lot of information. And so hopefully this was helpful. And I appreciate everybody's thoughtfulness about this.
And I just wanted to first say, RASopathy Network thanks Dr. Bruce, Dr. Stevenson, and Dr. Roberts for being here today to answer our questions and walk us through this, because I know that I had a lot of questions too when my 12-year-old with Noonan syndrome was vaccinated. And I loved hearing the first webinar to help make those decisions. And I hope this information helps you, with your decision on vaccination. So thank you, everyone. And thank you, Elizabeth. And we're going to miss you. And if anyone else would like to join the RASopathies Network board or volunteer for us, please reach out to info@rasopathiesnet.org. And we will see you all soon. Oh, and if you have other webinar suggestions, we want to do one on seizures, but if you have other suggestions on webinar topics, please email again, info@rasopathiesnet.org. Thank you.
Stay well, everybody. Bye.